thank you for this invitation to talk to you today about living with HIV and other serious comorbid or multimorbid illnesses. So I'd like to start with some good news. Here's some analysis of the WHO mortality data that we published recently in Lancet Global Health. So we look at the data on the number of millions of people dying with serious health-related suffering projected from 2016, which is the blue circles, to 2060, which is the red circles. Now, the great news, of course, is actually the number of people dying with HIV and serious health-related suffering is going to reduce in the years to 2060, which is fantastic news. Of course, the corollary of that with aging with HIV is that increasingly we are going to see people dying with other conditions. So we can see from the top three lines of this graph that to 2060, we're going to see a big increase in the number of people dying globally with cancers, with cerebrovascular disease, and with lung disease. And of course, within that, there are going to be people dying with HIV and those conditions. So it's a changing landscape of what we're going to be dying with over the next 50 years. So let's think a little bit now of the evidence for aging and comorbidity. Now, in terms of malignancies, when we look at projections within Europe for people living with HIV, an increase in the number of infection-unrelated malignancies for people living with HIV, and a decrease in the number of people with HIV and infection-related malignancies. Of course, that's about treatment and it's about aging. And there's been an increase in deaths with non-AIDS defining cancers in high-income countries, and non-AIDS defining cancers are becoming a large proportion, about a quarter of all non-AIDS deaths among people living with HIV. In terms of comorbidities, people in the UK over 50 living with HIV, over half have at least 2 comorbidities, and projections from the Netherlands saying that among people living with HIV, around a third will have 3 or more comorbidities by 2030, and these will be largely cardiovascular disease. When we look at cardiovascular disease incidence for men in the USA by age 60, we can see that around a fifth of people who are HIV infected and on treatment will experience cardiovascular disease. Around 15% for people without HIV but at high risk, and about 13% in the US general population. So we can see an elevated risk for cardiovascular disease. And of course, how people experience care will change as well. So older people living with HIV in the UK express concerns about the HIV skills, amongst clinicians and the other clinical specialties that they'll be attending, how their care will be coordinated, and also, of course, around confidentiality because of the very specific issues around stigma in HIV. Now, of course, there are lots of theories around minority stress and biological outcomes. Here's a really nice paper that's a systematic review of the primary evidence for the biological outcomes of minority stress. Now, this is in the context of LGBT+ people, but we can see how the experience of minority stress may have some moderators, but then there are mechanisms whereby biological functions are affected, and there are potential clinical outcomes from experiencing here discrimination due to being LGBT+, which has then implications and worse outcomes for the incidence of cancer, heart disease, high blood pressure, susceptibility to infections. So what we can see is actually there's maybe a greater risk of some of these comorbidities simply because you are part of a minority group, which of course HIV has always disproportionately affected minority groups. And again, if we think a little bit more about LGBT+ communities, and of course gay men have sex with men particularly affected by HIV, we can see that LGBT+ people already have greater all-cause mortality, higher lifetime risk of certain cancers, maybe less likely to routine screening because of fears of discrimination. Once in cancer care, LGBT people report worse cancer care experiences. Building on that model I've just shown you on minority stress behaviours, higher risk behaviours are linked to discrimination, and all kinds of implications from increased alcohol consumption, increased use of smoking and drug use. And then in terms of advanced disease care, there's lots of concerns around heterosexually biased environments, lack of support, and failure to involve partners in critical decisions. A bit more widely about serious comorbid illness and key populations. Here's some work conducted by my colleague Jenny Hunt in Zimbabwe. If you're a female nurse and a sex worker comes as a patient, you would rather say, let her die because she's corrupting my husband and disturbing my marriage. So actually, you may have great comorbid illness simply because there's been a values-based decision to refuse prevention, treatment, or care. And I think this title of this paper, published by Jen and her colleagues in Zimbabwe, speaks volumes. So isolation comes in, discrimination, and you find many people dying quietly without any family support. And then, of course, there are important considerations in aging and frailty. So in addition to what you might anticipate to be the normal comorbidities associated with aging, we already know that there's a higher prevalence of anxiety and depression amongst people living with HIV compared to the general population, and actually much higher than cancer and diabetes patients. We know there are theories of accelerated aging and chronic infection, which is demonstrated also in evidence of a greater risk of clinically weak grip strength and match controls amongst people living with HIV. And we also know that HIV is independently associated with frailty and pre-frailty amongst patients living with HIV compared to uninfected controls. So what do we need to do about this? So here's a really nice paper in Current Opinions. Evidence-based strategies are needed to address the growing complexity of care of those aging with HIV, so that as life expectancy is extended, quality of life is also enhanced. So I think that's a really clear framework for us to consider how we may better care for people living with HIV and comorbidity and aging. So I find this slide incredibly helpful. A colleague of mine, Carla Alexander from the Institute for Human Virology in Baltimore, coined the phrase from the life of the virus to the life of the host. So really for me, this is the entree to person-centered care when we consider care at the intersection of physical concerns, social concerns, emotional concerns, and spiritual concerns. And if we focus on these outcomes and we measure them, we may be more able to ensure good quality care that's accessible and reflects what matters to the patient. So we've recently published this systematic review looking at the empirical evidence underpinning the concept and practice of person-centered care in serious physical illness. This was led by Alessandra Giusti in BMJ Global Health. What we did was collect, we looked at Santana's model of person-centered care, the framework, which looks at the structures, processes, and outcomes of person-centered care. And then we inductively and deductively coded from the existing evidence to this model and looked how we could expand it to really understand what person-centered practices look like. So care processes should really promote continuity of normality and self-identity, which I think is really crucial for many of the populations of people living with HIV, involving family and friends in information sharing and decision-making. But also, really importantly, when we look at what we know about frameworks for person-centered care, we do know that we need more primary data that understand the meaning and practice of person-centered care in a greater diversity of people within broader universal values and ethical theory. And I think particularly in HIV, we have a tradition of being person-centered, but I think there's much more consideration of what that might mean for different populations. Also, when we're thinking about living with HIV and living with other comorbidity, we really need to think about living with clinical uncertainty, because HIV historically was associated with uncertainty. And I think comorbidity brings back that uncertainty. And Michelle's model of the four main types of clinical uncertainty is really helpful here. Complexity, because of course you're managing HIV and other conditions. Unpredictability. A lot of these conditions we're looking at, lung disease, cardiovascular disease, are associated with exacerbations and loss of function, some of which may be recovered, some of which may not be, and the end of life is unpredictable. Ambiguity is a really difficult concern for patients to live with, and often lack of information, and how you manage information from different specialties to really make person-centered decisions. So what does that look like for somebody living with HIV? Well, COPD is predicted to be the third leading cause of death by around 2030. So living with lung disease is extremely anxiety invoking and causes lots of problems with function. Here's a man living with HIV and COPD. I invariably go into accident emergency at Hospital X. We're on first name terms. They clerk me in easily. I've had excellent care. But if I go to Hospital Y, it's not a nice place to end up. They don't have a backstory there, and it's hard to go through 20 or 30 years of history when you're breathless. Before, they would drive me further away to Hospital X. Now they don't think I'll make it, so I have to go to Hospital Y. So for somebody living with HIV, there's a lot of complexity to describe, and that can be quite difficult if you're breathless and in A&E. The other main symptom I've had is falls. I have Cushing syndrome from the steroids, terrible leg pain and leg weakness, and I get stuck in the bath. So here we have some of the symptoms. We have some of the social problems. Can't bath himself without getting stuck. And then that's put him at suicide risk with severe worrying. So we can see he has psychological concerns as well. So this is a complex set of needs to be assessed, identified, and met. Here's a gay man living with HIV and prostate cancer. Not knowing what's out there and what's going on out there, I find it difficult asking the right questions. And I finish up spending an hour or somebody's time just trying to work out what's good for me. And that really comes back to Michelle's model of decision-making and information when you're living with a number of diagnoses, each of which may bring some uncertainty. Here's some nice work by Mary Ofei from Ghana, working with people living with HIV there, asking what does person-centered care look like? And we also know, of course, one of the challenges is already have a population level higher prevalence of comorbidity than in some high-income countries. So people living with HIV want access to information, they want involvement in care decisions, they want to be able to disclose their HIV status and their sexual orientation, which is challenging across conditions. They want that multidimensional care, and they want it to include social well-being. Healthcare professionals want to be able to give tailored care, and they have some issues with resourcing psychosocial care, but they do want to integrate it. And in terms of the shared views, being able to address financial problems is crucial. Delivering care within the community rather than from facilities is important. Reducing stigma, and also addressing some of the human and time resource issues when you're really trying to deliver high quality person-centered care. So what might be some of the challenges in delivering this quality of care? Well, when you're living with multimorbidity and HIV, there are real problems with communication when you're crossing specialty areas and decision making, and also great concerns about HIV stigma. When you're used to an HIV service which maybe is more attuned to some of the populations that are living with HIV and understands the issues around stigma and disclosure, and then all of a sudden you're attending cardiology and oncology, that can create a lot of concerns. And there's also may impact on the care that you receive. Here's some interesting data from Canada comparing place of death for people living with HIV compared to other deaths. People were dying younger still, but actually also spending more time in hospital, not dying at home, and also the costs of care and the costs of death were much higher. And person-centered care is often allowing people to make important decisions, like if you have make an advanced care plan, that if you have comorbidity or multimorbidity, would you like to die at home, which most people would choose to do. And that issue about confidentiality, disclosure, stigma is really crucial as well, particularly when you move out of HIV services, which may have a better handle of some of these things. Here's a lesbian woman whose partner had died of ovarian cancer, and really describes nicely that dance and that decision-making process, particularly as she describes your longer experiences of hiding your sexuality. Is somebody going to be negative about you? Are they going to make a judgment? At what point in the conversation do you actually acknowledge and do you state your sexuality? What sort of risk assessment do you do that when you're moving, for example, from HIV services to oncology services? And also, we need to think about the epidemiology in HIV, and of course, it's had a huge impact in low and middle income countries. So where's our evidence base? If we look at something really simple like advanced care planning, which would be hopefully a routine intervention for people living with uncertainty and progressive incurable conditions and comorbidities such as lung disease, heart disease, malignancies, an advanced care plan would be a normal thing to deliver. Cheng Pei Lin from our department did a really nice systematic review of the conceptual models and mechanisms that underpin advanced care planning. And he discovered that it's going to be really important for us to better understand the cultural feasibility of the logic model for different education levels and ethnicities in non-Western countries, and they should really be a research priority. And also we've done some work led by Janet Stanford in South Africa, talking to Xhosa populations, where absolutely, yes, the concept of an advanced care plan was welcomed and seemed to be important. However, even though it's an important concept, do people really have the resources to deliver on your choices? If you live in a low and middle income country and you make a choice about how you'd like to live the rest of your life, is advanced care planning a fairly individualistic process when this may not be appropriate in collectivist cultures? And actually, if you're a woman, do you get to make choices? Does gender mitigate against some of those decisions you might make? It's really important, of course, to think about HIV and rehabilitation when we're thinking about multimorbidity and comorbidity. I'd really like to highlight the work led by Kelly O'Brien at the University of Toronto and the Rehabilitation and HIV Association. So we've got a nice definition there of rehabilitation, which aims to reduce impairments, activity limitations, or social participation. And the Canadian Working Group has been doing a lot of work on HIV and rehabilitation. Of course, Darren Brown also in the UK. Kelly led this HIV rehabilitation evidence synthesis to come up with some overarching recommendations on the integration of rehabilitation for people living with HIV, which of course is absolutely key in most of the comorbidities that we will be seeing as people age with HIV, like lung disease, like cerebrovascular disease, like malignancies. So rehabilitation in HIV, we need to include rehabilitation professionals. Do we have those links? Do we have services available to refer for people living with HIV? Are we able to really take that individualized approach, sensitive to the individual and their values? Are we going to get multidisciplinary rehabilitation for our HIV patients? Are we going to really understand some of the extrinsic contextual factors that people living with HIV already described in the literature, some of that stigma, in addition to the issues of ageism? And rehabilitation professionals need to really understand how people can better self-management. We've certainly done a systematic review on self-management of symptoms, particularly pain for people living with HIV, and it's entirely as possible, and there are some effective interventions out there. Aerobic and resistive exercise can be recommended for people and has a good level of evidence for effectiveness. Also, cognitive rehabilitation needs to be made available. And we need to also refer to other recommendations for specific comorbidities. So you need to look at people's HIV, but also what are the recommendations for their pulmonary rehab, for example. A really important part of well-being, particularly in HIV, is spiritual well-being. We did some work with African communities in the UK, building on some of our work we'd conducted with colleagues in sub-Saharan Africa. And I was absolutely delighted that Desmond Tutu endorsed these recommendations, and some really key things about understanding your patient's beliefs, making sure that you assess and manage their spiritual distress, knowing who your local spiritual care providers are and having relationships with them, making sure they invite them into your setting and having some mutual training would be really, really important. And of course, pain is probably the most prevalent problem across HIV and these comorbidities. And there are interesting cultural dimensions on that. We know that people of African and Caribbean origin have undertreatment of pain, and that actually pain may be interpreted differently. So in advanced cancer in the UK, we've had patients describe their pain as a punishment and a test of faith that doesn't need analgesia. So it's going to be really important to do culturally appropriate assessment and discussion of pain and other symptom control. Of course, it's really important when we're thinking about HIV and comorbidity, now that people are dying older, we need to think about good bereavement, because that's part of care. We need to be thinking about bereavement services for friends and families. So we've done some really nice work looking at the evidence for LGBT plus bereavement, and of course in many different contexts there are going to be complex issues around the spokenness or unspokenness of the relationship, how accepted or unaccepted it is. And Catherine Bristow led this model with Steve Marshall, trying to understand how some of those factors might influence the bereavement experience. So as a clinical service, we need to understand those variables. So where a patient might sit in the model and their family, but also thinking cross-culturally about bereavement is really important. Barbara Mutedzi in Zimbabwe is doing some great work on feasibility of bereavement models in Chitungwiza. It's really clear from her paper there's a paucity of data on bereavement prevalence and interventions from sub-Saharan Africa, although community-based interventions look most promising. And Barbara, with Jenny and colleagues, have been doing exactly that, looking at the feasibility of a bereavement intervention. It's important for us to think about what's an important outcome when somebody's living with a multimorbidity. So the lifetime prevalence of death is 100% and will continue to be so. Testing and treatment and all the other things we advocate for in HIV will not reduce that. We need to drive quality by measuring what matters to people. We absolutely need to prevent HIV, we absolutely need to treat HIV, and we absolutely need to understand what matters to people. And when we look at this data led by Public Health England, as it was, and Anne Sullivan and Beaver, looking at 206 deaths from the London death audit for people living with HIV, a third of those deaths were unexpected, which is really very interesting. But even when they were expected, a majority of the deaths happened in hospital, which is not where people want to die. A good thing is that 2/3 of expected deaths had a documented prior end-of-life discussion. But of course, that leaves a third of people without one, so we need to be having those conversations. And it's really interesting, the iPod study, International Place of Death study, led by Joachim Cohen at the University of Brussels, looked at HIV deaths, worked on this data with him to find that actually hospital death is most common in all countries studied. And people are more likely to die in hospital and less likely to die at home if they have HIV compared to cancer patients. So what do people living with HIV say matters? Well, here we have a person living with HIV saying, I think I'd like to hear them say, how's your physical health? How's your weight? How's your mobility? Is there anything going on there? But the people that pay for, i.e. purchase health service, HIV services, so the people that commission those services say, I'd like adherence to be discussed in their clinic appointment. I'd expect them to be updated on blood results and partner notification. Very different view on what matters and what we should be measuring. When we ask patients generally what matters when you've got serious comorbid illness, it's really clear they want good pain and symptom control, they want family support, they want to be listened to, they wanted resolution and peace, and they wanted integrated care with continuity of provision. So those are the things that matter. I hope you've all seen the new WHO Consolidated Prevention, Testing, Treatment, Service Delivery Monitoring Guidelines. Delighted to say we've been working with WHO, and there is now a palliative care chapter as an essential component of HIV services. We know from a prior systematic review that HIV palliative care improves outcomes, including pain and symptom control, anxiety, insight, and spiritual well-being. And we also know that palliative care is cost-saving, improves outcomes, and can even improve survival when you reduce burdensome futile treatments and focus on managing quality of life and symptom control. So the WHO essential package for people should be safe, effective, inexpensive, off-patent and widely available medicines, simple, inexpensive equipment, basic social supports, and the human resources needed to deliver that. So I please urge you to all have a look at that. And it's interesting to think specifically in context what needs might be. So Dayo Afolabi from Nigeria has just published this really nice systematic review of what matters for people with serious illness who may be approaching the end of life in sub-Saharan Africa. So it's really clear in the WHO new consolidated guidelines that people living with HIV should have access to palliative care at all levels of healthcare systems and in the home. Central level hospitals, district hospitals, and primary healthcare centres. And there's more detail in this guidance on planning and implementing services from the WHO. And if we do that, what might we achieve? Here's a study that colleagues ran, led by Clint Cupido's study in a service in Wynberg in the Western Cape. If you introduce a hospital-based palliative care service here in South Africa, what you can do for patients with advanced illnesses: reduce admissions, reduce mean days admitted, reduce total admission days, reduce bed day costs, and enable people to die at home. And this was a simple intervention. And once we start thinking about patient-centered outcomes, there are all kinds of things we can do. Colleagues in Africa are embedding routine patient-reported outcome measures into audit, training, management, resource allocation, and research. So the big SIPO USAID program in South Africa has got patient outcomes embedded at the heart of it. Developing important work for children, enabling children to identify what matters to them and their priorities, and also for people with low literacy, they can still be enabled to report and score what matters to them. And a really simple thing we can do is just teach existing HIV ART clinical nurses how to do person-centered care. And here's a simple RCT we ran in Kenya with some colleagues in Mombasa. And if you did a simple 2-week course on the principles of person-centered care, borrowing from palliative care, for patients on HIV patients on treatment, you can improve mental health, psychiatric morbidity, and psychosocial problems. It's a very simple intervention. So where are we now? In conclusion, well, uncertainty, of course, is revisited, but quality care needs us to revisit it, because people now are going to be living and dying with complex comorbid and multimorbid illness. So we need to focus on the individual as well as the diseases. Universal health coverage requires now us to deliver prevention to palliation. So we need to think about optimal quality of life and informed decisions. And I would urge you to look at the HIV outcomes website to be thinking more about quality of life. Exciting interventions are being developed. Jaime Vera and Catherine Bristow are developing the Silver Clinic, so a specific service screening for pre-frailty and frailty for older people with HIV, and doing multidisciplinary assessments. And there are simple tools we can use for multi-dimensional person-centered assessment, such as positive outcomes. And I'm really pleased to say that the latest standards of care for people living with HIV from 2018, these are developed every 7 years, developed with community and healthcare professionals, now includes standards of care on person-centered care, on patient-reported outcomes, and on end-of-life care. And I would also lastly draw your attention to the consensus statement on the role of health systems on advancing long-term well-being of people living with HIV, which talks a lot about comorbidity in nature communications. Thank you very much for your attention and the invite today.